In June of 2017, a 26-year-old restaurant manager in Minnesota named Alec Smith was found dead in his apartment. He had type 1 diabetes, which means his body makes no insulin, and without it, you die. Alec wasn't reckless. He worked full-time, but he had just aged off his mother's health insurance, and the insulin he needed to stay alive was costing him around $1,300 a month. So he did what a lot of people quietly do. He started rationing it, stretching each vial to reach his next paycheck. He didn't make it. How does a drug that's been around for a century and is estimated to cost only a few dollars to make end up costing a young man his life? That's the question. Here's the math he was facing. When Alec turned 26 in 2017, he aged off his mother's plan, the cutoff the law sets for dependents. On his own, the cheapest insurance he could find still carried a $450 monthly premium and a $7,600 deductible, meaning he'd face the full cash price for insulin until he reached that deductible, and he couldn't cover that up front. So he went without insurance and paid cash. And his mother says his insulin and supplies came to around $1,300 a month. To make it stretch, he rationed. Weeks later, he died of diabetic ketoacidosis, what happens when the body runs completely out of insulin. His mother has since become one of the loudest voices for insulin reform in the country. So let's answer it like an operator. Why does insulin, a drug discovered in 1921, whose inventors famously sold their patent rights for about $1, hoping it would stay affordable, cost so much in America? Here's the twist that makes this different from the shortages we've covered. Nobody is running out of insulin. It's sitting right there on the shelf. The problem isn't supply, it's the price tag. And the story behind that price tag is one of the strangest in all of healthcare, because the list price you see has almost nothing to do with what most insured patients actually pay, and yet it's exactly what someone with no insurance gets billed. Let me untangle it. Take one common insulin, Eli Lilly's Humalog, a modern lab-made insulin that launched in 1996. That year, a vial listed for about $21. By 2016, that same vial listed around $255. By 2017, roughly $275. Once it launched, the molecule itself didn't change, but the price climbed roughly 13 times over 2 decades. Nothing about the science changed to justify that climb. So something else was driving it, and to find it, you have to follow the money. Because this is where insulin gets strange. Start with what it costs to actually make. Independent experts, not the companies, estimate a vial of insulin can be manufactured for somewhere around $3 to $10. That's an estimate, not an audited figure, and it varies by product. But even at the high end, you're looking at maybe $10 of manufacturing against a list price that had reached about $275 by 2017 and kept climbing after. So the obvious guess is that the drug companies are simply pocketing the difference. And that guess, it turns out, is mostly wrong. The truth is stranger and more revealing. Because here's the fact that breaks everyone's intuition. Over the very years that list prices were exploding, the amount the insulin makers actually kept per vial was going down. Both things are true at once. To see how, you need to meet the middlemen. In a peer-reviewed analysis of insulin from 2014 to 2018, the average list price, the sticker, rose about 40%. But over those same years, the net price, the amount the manufacturer actually collected after all the behind-the-scenes deals, fell by about 31%. Read that again. The sticker went up 40%, while the maker's real take dropped by a third. That gap between the list price and what's actually collected is where this entire story lives. It even has a name, the gross-to-net bubble. First, the makers. Just 3 companies, Eli Lilly, Novo Nordisk, and Sanofi, supply over 90% of the world's insulin, and close to all of it in the United States. For most of that century, almost no one new entered the market. Part of it is that insulin is a biologic, grown in living cells, and until very recently, there was no real pathway to make a cheap, substitutable copy the way you can with an ordinary generic pill. Patents, sheer scale, and the cost of the pens and devices kept newcomers out too. So you have 3 sellers, no cheap competition, and a product people will literally die without. That's the setup. Now here's the machine that turned that setup into a $275 sticker. In the middle, between the drug maker and you, sits a company called a pharmacy benefit manager, a PBM. Insurers hire PBMs to decide which drugs get covered. To win a spot on that list of covered drugs, a maker pays the PBM a rebate, a cut of the price, and critically, that rebate is typically tied to the list price, often a percentage of it. So watch what that quietly rewards. The higher the maker sets the list price, the bigger the rebate it can hand over to win coverage. The list price stops being what the drug costs and becomes a number chosen to feed the rebate. Almost everyone in the middle has a reason to want it high. How big do these rebates get? A bipartisan Senate investigation in 2021 found insulin rebates climbing well past half the list price, in some cases 70% or more. One manufacturer told the Senate it stayed profitable even while handing back up to 89% of the sticker. Sit with that. A large share of that $275 list price can be passed through, money routed to the middleman to secure a spot on the formulary. The maker still sets that price and still profits, but the number printed on the vial was never really just about the drug. You can see the shift in the money itself. Of every $100 spent on insulin in 2014, the manufacturer kept about 70. By 2018, that was down to roughly 47. The missing money didn't vanish. Most of it moved to the middle, above all to the pharmacy benefit managers negotiating those rebates, with smaller slices going to wholesalers and pharmacies. So when people picture a drug company pocketing the entire $275, that's not what the data shows. The money increasingly gets split across a chain of middlemen, each taking a slice on the way to the counter. But here's the cruel part, and it's the part that trapped Alec Smith. All those rebates flow backward to the PBM and the insurer. They almost never reach the person standing at the pharmacy counter. If you have good insurance, the system quietly absorbs the inflated list price behind the scenes. But if you're uninsured or stuck under a high deductible, you're the one exposed to that full pumped-up list price. The very number that was inflated to fund a rebate becomes what the most vulnerable patient gets billed. On the insulin itself, Alec paid that undiscounted list price, inside a reported $1,300 a month bill for insulin and supplies combined. And these middlemen are not small players. As of 2025, about 80% of all US prescription claims run through just 3 pharmacy benefit managers, the ones owned by or tied to the biggest insurers and pharmacy chains. So on one side, you have 3 drug makers, and in the middle, 3 PBMs. A handful of companies on both ends quietly setting the terms for a medicine that millions of people need every single day. There's one more pattern worth naming. For years, whenever one insulin maker raised its list price, the others tended to follow, close behind in strikingly similar amounts. Investigators have scrutinized this lockstep pricing for signs of coordination. Nothing has been proven to be illegal collusion, and I'm not claiming it was. But the effect for a patient is the same. 3 companies, prices marching upward together and nowhere cheaper to turn. You might wonder, isn't there an older, cheaper insulin? There is. A big box store sells an older generation human insulin over the counter for around $25 a vial. But it works very differently from the modern rapid-acting kind. Different timing, different dosing, a different eating schedule, which makes switching between them genuinely dangerous without a doctor's guidance. In 2019, a 27-year-old named Josh Wilkerson, priced out of his roughly $1,200 a month analog insulin, switched on his own to the cheap over-the-counter version to save money. That unsupervised transition went wrong, and he died. To be clear, this isn't medical advice, and older human insulin keeps millions of people alive every day. The system's point is narrower. When the only affordable option forces a risky, unsupervised switch, the price of insulin has itself become the danger. After years of stories like these, something finally moved. In 2023, a federal law capped what people on Medicare pay for each covered insulin at $35 a month. That same year, under enormous public pressure, Eli Lilly cut its list prices about 70%, and Novo Nordisk and Sanofi followed with their own cuts, plus $35 savings programs for many patients. For a lot of people, insulin genuinely did get cheaper. So, problem solved? Not quite. The Medicare cap clearly worked for the people it covered. The share of Medicare enrollees paying $35 or less for insulin jumped from about 48% before the cap to about 75% after. Real relief for millions. But notice the flip side. Even within Medicare, about 1 in 4 still paid more than $35, often on extended multi-month supplies that get billed differently. And more importantly, that federal cap only covers Medicare. It doesn't touch everyone else. If you're on Medicare, you're largely covered. But if you have job-based insurance, or a marketplace plan, or no insurance at all, there is no federal $35 cap for you. Many states have passed their own caps. But those state laws don't reach the big self-funded employer plans that cover a huge share of working Americans, because federal law exempts them. So the safety net is real, but it's full of holes. An uninsured worker like Alec today still has to hope a manufacturer's savings card comes through. And it isn't automatic. You have to know to ask. There is some genuine hope on the horizon. Regulators have finally approved interchangeable biosimilar insulins, copies that, where state law allows, a pharmacist can substitute directly, and that could push prices down. A non-profit maker has promised insulin at $30 a vial to anyone, insured or not. But these efforts are arriving slowly, and some, like a state-run insulin project in California, are already running behind schedule. The fix is coming. It just hasn't fully arrived. So put it together. Insulin costs so much not because it's expensive to make. It isn't, but because only 3 companies dominate it. Because the list price got inflated to feed rebates to middlemen. Because much of that rebate stays in the middle instead of reaching the patient. And because the person with no insurance is billed that inflated list price. The makers still set the price and still profit, and the middlemen still take their cut. The number on the vial was never really just about the drug. Alec Smith didn't die of a shortage. He was failed by a pricing system, and that system is finally, slowly starting to change. If you want the operator's view of how healthcare actually works, the system's behind the headlines, in plain English. The breakdowns are at shanewelter.com/free. Next in this series, we walk right up to the pharmacy counter. There's no line, no one ahead of you, and yet they tell you it'll be 20 minutes. What on earth are they doing back there? It turns out it's a lot more than counting pills. That one's next.